Hello, everyone. Thank you for attending today's webinar, Combating Workplace Violence in Healthcare, Strategies from the Frontline, presented by Everbridge. I'm Andrea Anderson, and I'll be moderating this webinar. Our speaker today is Paul M. Sarnis, Assistant Vice President of Safety, Security, and Emergency Preparedness at Virtua Health. You can read his full bio on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your volume is up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. All right, let's begin. Paul, please go ahead.
Thank you, Andrea. And good afternoon, everybody. Thank you for taking time out of your busy schedules to join this webinar. It's going to be a little fast-paced. We're going to cover a lot of information today. We're going to talk about workplace violence. We're going to cover some statistics, some challenges, some opportunities, some of the best practices for structuring a successful workplace violence prevention program in healthcare. We're then going to transition to active shooter. We're going to define what an active shooter is, provide some statistical data, and then talk about how the best practices really for implementing a active shooter response plan, as well as exercising that plan. Then after that, we'll transition to the mobile worker safety, and again, talk about some challenges that our employees in the communities face, and then talk about some solutions to provide them with some mitigation strategies to keep themselves safe. So we'll get started here. So a lot of definitions about workplace violence. You'll find the World Health Organization has a definition, CDC, OSHA, the World Medical Association. Many organizations have different definitions for workplace violence, very similar to terrorism. There are about 15 different definitions of the word terrorism, depending upon what part of the world you're from and what organization that you're referencing. This, I believe, is one of the most comprehensive definitions. This is from the Joint Commission. Myself and other members from the International Association for Healthcare Security and Safety had the opportunity of sitting on the advisory council to work on this definition. And I think this is very comprehensive. Any act or threat occurring at the workplace that can include any of the following: verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, or humiliating words or actions. I love that the next couple words were added: bullying, sabotage, sexual harassment, physical assaults, and other behaviors of concern involving staff, licensed practitioners, patients, or visitors. We do know that 85% of the assaults that occur on healthcare employees are committed by the patients that we're providing services to, but we know that there are other risks outside of just the patients that we're providing services to. Statistics, there's a ton of them. We are 4 or 5 times more likely to be a victim of an aggravated assault than any other industry. Unfortunately, in some places throughout the world, the most dangerous place to work is in the emergency department, and the most dangerous job to have is that of a caregiver in the emergency department. These statistics, I think, give just a very broad overview of just how bad it is. I mean, this is an international problem. The World Health Organization declared workplace violence an international problem. It's almost like a pandemic in itself. For those of us that certainly have to tie some financial data to workplace violence, I think this slide will provide a lot of great information that you can share with your leaders. We know that to establish a successful workplace violence prevention program, resources are required. The resources that we may be requesting to improve our program need to be looked at it as an investment, not as an expense, because investments save dollars in the future. So an investment in a workplace violence prevention program could decrease your workers' compensation claims, could decrease your turnover, could increase employee engagement, employee retention, and assist with recruitment. So the first slide was basically just some facts and data about where we're at today. And then this is really for those of us that need some financial data to support maybe some of the resources that we may be requesting in the future. So when you look at a successful workplace violence prevention program in healthcare, this is right from OSHA. This is the components of a successful program. This has been around since the 70s. Um, these are the key foundational things you need in place: management commitment, a worksite analysis looking at the physical environment to include not only the inside of the facility, but also the surrounding community, maybe in a 3 to 5 mile radius around the facility, looking at the crime there. Hazard prevention and control, those things that we can do, right? You look at the hierarchy of safety. If we can engineer something out, let's engineer it out. If we can't engineer it out, what administrative controls can we put in place? If we can't use administrative controls, what type of personal protective equipment can we put in place? So it's looking at those mitigation strategies. Education and training, it's huge. There are a lot of different programs out there that are available to help staff identify and manage aggressive behavior. Organizations have to choose one that's right for them and then fully implement that. Employee support and resources. We know that employees that are the victim of aggression at work site do um, suffer from physical injuries, psychological injuries, um, stress, anxiety. So we have to make sure that we are providing our employees with the available resources so that they can heal and move forward. Because our goal is to what we want to prevent is somebody from leaving our organization or somebody leaving the profession as a whole. And we know that the migration from healthcare right now is pretty significant. And then certainly, once a program is implemented, we need to evaluate it. Is it working? Are the goals that we established being achieved? Um, so this is the foundational framework for a successful workplace violence prevention program. So we all know without leadership support, nothing happens. No new initiative is going to be successful. No program is going to have any sustainability. We need leadership support. The Joint Commission was very purposeful in how they designed the elements of performance and the standards around workplace violence. Failure to implement a workplace violence prevention program in a healthcare organization that is accredited by Joint Commission is a leadership citation or a citing. Um, I always look at a Joint Commission inspection as almost like a report card for the CEO and the Board of Trustees. And no Board of Trustees and no CEO or COO is going to want to have an F on their report card. So very purposefully done by the Joint Commission. But here it is. Joint Commission requires a violence prevention program, including leadership oversight. That means that the chair of the Violence Prevention Committee should be a leader, should be a vice president, somebody who has the authority to implement change and really get the support of the organization. The best program I've seen so far in the country is the COO of a large health system is the chair of the Violence Prevention Committee. And she, on a monthly basis, sends out an email or a newsletter to the organization about the activities of the violence prevention program coming from her. And to me, that sends a powerful message to the staff of how important it is. So we need that. We need leadership. We need to make sure we have policies and procedures. And if you need any help designing your program, please reach out to me. No need to reinvent the wheel. Policies, procedures, a reporting system that captures good data, reporting system that's easy and there's no barriers in front of an employee to create a report. And certainly we need the culture that's going to support employees reporting incidents without any fear of retaliation. Data is everything, right? We don't make any decision today without data. We don't allocate any resources without data. We don't support new initiatives without data. So we need to make sure that we have good, clean, accurate data. And we need to make sure that that data is getting to the decision makers. Unfortunately, a couple months ago, I had the distinct displeasure of telling a president and CEO that the incidents of workplace violence from 2020 to 2021 increased by 178%. He heard it from me. I did not hear it from inside his organization. You can imagine how upset he was with hearing that from an outsider, so to speak. We have to make sure your board's aware of this information as well. So data is very, very important. Post-incident strategies. Are we providing our employees with the right support so that they can heal medically, psychologically? Are we providing legal support if necessary and so forth? So we need to provide all these different things. Worksite analysis is huge. So again, it's not only looking at inside the four walls of a facility, it's also looking at the community because our parking lots are in the community. Our employees walk many of our employees walk to work, we need to certainly look at the totality of the environment in which our employees are working. So a comprehensive security vulnerability analysis should include at least a 3 to 5 mile radius around the hospital, really looking at the crime and the risk that our employees may be exposed to. We also have to make sure that the people that are doing the assessment are credentialed to do the assessment. So, there is a certification offered by the International Association for Healthcare Security Safety, which is really the premier organization that's really solely dedicated for healthcare safety, security, and emergency management. It's been around for 53 years. We offer the Certified Healthcare Protection Administrator course. If you're looking for an outsider or consultant to provide your assessment, this would be the credential that I would strongly recommend that they have. When you're doing the assessment, certainly you can choose to do it in-house. You can choose to bring in a consultant. You can choose to have a team from around your organization or around your system to come and look at it. But the things you really need to look at is access. How are people getting to the campus? So multiple layers, multiple circles. How are individuals accessing the campus? How are they accessing the facility? How are they accessing sensitive areas? Are there clear lines of delineation between an employee area and a patient area? That's really the term of territoriality. So I always, doing an assessment, I walk the path of the patient. And as a patient, as an outpatient, I should not be able to get into administration. As an outpatient, I should not be able to get into the kitchen. To the cafeteria to get my food, maybe, but not into the back of the kitchen. So really walking the paths and making sure that there are kind of clear lines in the sand where we're controlling access to. So access and territoriality are very, very important. Surveillance. Certainly, do we have cameras that are looking at access points? Are they looking at decision points? Like, can I go left, right, straight? Are they in those high sensitive areas, emergency department waiting area, and our medication distribution rooms, and our areas where we collect cash or count cash, or where there's other sensitive equipment? So you really want to look at surveillance. It's also direct line of sight. So not only is it cameras, it's also the clinical team being able to see the patients in the waiting room. There are many hospitals that are hundreds of years old, and they weren't designed to meet today's standards. So their waiting rooms need to be monitored by staff. If you can't get that direct line of sight, then you want to consider doing a camera and a monitor so that you can at least provide the safety to the patients there. Lighting is incredibly important. We know light is a deterrent. So doing comprehensive light analysis to make sure that the illumination standards are being adhered to. Emergency communications. Can I call for help when I need it? Am I working by myself? Can I call for help? Is it through a phone? Is it through a radio? Is it through a panic button or a duress button? Staff need the ability to be able to communicate in the event of emergency. And then whatever equipment is deployed, this is typically where you find some issues, unfortunately, is the maintenance of the equipment. Are the cameras being maintained? Is the access control system being maintained? When you push the panic button, does it work? And if it does work, does it bring the security officers to the right location? So all of those things need to be included in that comprehensive analysis. And please don't forget, if you have a mobile workforce, they need to be included in your violence prevention program. So when we talk about violence prevention, it is all about risk management. I was taught this TRIA 20 years ago, and it stuck with me. TRIA is transfer the risk, reduce the risk, eliminate the risk, or accept the risk. And that's really what we're doing. This is really measuring the organization's risk tolerance. So if we identify a risk during an assessment and there is no action taken, that's accepting the risk. If there is a mitigation strategy, that is reducing the risk. If it's an engineering control or something else, which is preferably to eliminate the risk. But it's really risk management when you break it down. When it comes to data, typically what you see in organizations is there's multiple sources of data. There's the security incident reports, there's the employee health and safety reports, which are all about workers' compensation claims and employee injuries, and then you have an occurrence reporting system. Certainly they need to be easy, accessible, and so forth, but many times they're presenting 3 different data points. So we need to ensure that organizations identify that source of truth Like there are some organizations that on a monthly basis or a quarterly basis reconcile. They look at the security incident reports, they look at employee health and safety, they look at the occurrence reports to actually determine what is the true number of employees that were assaulted this month. And then can you break it down? Time of day of week, location, occupation of the injured, body part injured, cause of injury. All those details will allow the organization to determine what areas or staff are at the most risk. So I'll tell you one quick story. Organization did a review of an organization's data and found out that the organization was unaware of how many of their employees were actually bitten by patients and residents. This was a long-term care facility, so the residents were biting. They were providing training, but for the last 10 years never included anything about how to get out of a bite. The data will help you make those decisions and certainly focus your energies where you'll get the biggest return. Talked about de-escalation training. There are a ton of programs out there that teach staff how to identify and manage aggressive behavior, teaching the verbal warning signs, physical warning signs, de-escalation skills, and then, how to get out of a wrist grab, a hair pull, a choke, a bite, a bear hug, whatever it may be. You need to choose the program that is best for your organization. There are some that are geared towards geriatrics. There are some that are geared towards the DD population. There are others that are geared toward pediatrics. There are others that are geared towards the general medical surgical units. So you really have to choose the program that is best for your patient population. And then obviously we have to implement it. We have to train our staff. God forbid one of our staff is injured. And unfortunately, we know what happens quite often, all too often. And I'm really glad that we're talking about violence prevention today, because really for the first time in my 34-year career, I feel that violence in healthcare is finally getting the attention it deserves. We see states passing laws almost on a monthly basis that strengthen penalties against threatening and assaulting healthcare workers, and it's a great thing. But we need to still always be there for our employees, right? Our employees are our most vital asset. Our employees need to come first. Employees cannot provide great patient care, and they can't help others heal if they're getting hurt at work. I mean, what we do in healthcare is in my mind, the most noble, impactful, purposeful thing that we can do as human beings. And that is helping other people heal, helping other people have the best quality of life they can. We got into this profession to help people. We didn't get in this profession to be hurt. In the event an incident does occur, we need to make sure that we're there for our employees. We need to make sure that they're getting free and quick medical care. We need to provide them with psychological support. If it's an employee assistance program, peer-to-peer counseling, critical incident stress debriefings, we need to provide them with support. One of the most important things that we can do as leaders in healthcare is reach out to the victim, reach out to the employee, and to see if they're okay. Interviewing staff for the number of years I've been doing this, that's one of the most impactful things we can do as leaders. I can't tell you how many employees said, I left this job because nobody called me to check to see if I was okay. They wanted to make sure I was coming in the next day to fill my shift, but nobody asked me if I was okay. So we have to make sure that we're providing our employees with the right resources, obviously. When we take care of our employees and we provide a safe environment for them, they can provide great care to our patients that they're serving. So we want to make sure that we're there for them. When we talk about the assessment, certainly we want to do a physical assessment, look at access control and surveillance and blind spots and workers working by themselves and, the environment as a whole. But we also need to interview staff, look at the data, see what's happening not only in the facility, but in the community around us. Recently at a facility that had a lot of concerns that actually was not even aware of the fact that a methadone clinic just opened up a block away from them, but they were concerned about all the needles that they were finding on their property, but had no idea that a block away, a brand new methadone clinic just opened up. You would want to know that as part of your risk assessment. So looking at the physical environment is important. Staff interviews, they will tell you what you want to know. Because we may think as healthcare leaders, we're doing everything to provide our employees with a safe and secure environment. But our employees may not feel it, and their perception is their reality. I was at a facility not too long ago where the perception was security is hands off. Security can't touch anybody. And it was so untrue. And, we started looking at the data and realized it wasn't true, but it was a staff perception. So those interviews are incredibly, incredibly important. So we have a program, right? We put our structure together. If it's a steering committee, a team, we do our analysis. We develop policies and procedures. We choose a training method. We deploy these. We have data we're collecting. We're evaluating it. We're making improvements based on that data. Every year, we have to evaluate it. Are we hitting our goals, whatever they may be? Reducing injuries, or the best goal that I always recommend is our number one goal: increasing reporting of workplace violence incidents. There's been study after study. One study actually said that 3% of incidents are reported. That was through the Mercy Nurses Association. 3% of incidents. Recently, through the American Organization of Nurse Leaders, 24% of incidents were reported. So, number one goal in my mind: increase the reporting. So that's really from a violence prevention perspective. Those are the foundational things that we need to deploy to have a successful program. And really great resources available to you. The International Association for Healthcare Security and Safety has a certification course that actually provides a certification to those that are charged with leading the workplace violence prevention program. A lot of great policies and procedures and training that's also available. All right, so now we're going to transition here to active shooter. The hottest topic in healthcare right now: workplace violence. Number two, hot topic: active shooter. And unfortunately, it's because of the hypersensitivity for the recent events, that have occurred throughout our country. So, active shooter. This is still the term that's used by the Department of Homeland Security, but you will hear things like active killer, active assailant. You will hear hunting and hunters. Just basically the same thing. In our country, guns are the most prevalent tool that's used to cause harm. Other countries that don't have access to the weapons that we do, it's chemicals, it's cars, it's machetes, it's swords, it's other tools. So just realize they're kind of interchangeable. They're saying the same thing. But an active shooter is one or more individuals actively engaged in killing or attempting to kill as many people as possible. And these are typically occurring in highly populated areas. These are not random events. These are the active shooters fantasize about the event. They plan the event. They practice the event. They start to purchase equipment like body armors and bullets and other things that they're going to need for the event. They actually practice it. How long will it take me to get there? Where's my escape routes? So these are not things that, we used to use a term years ago. Somebody went postal. This is not somebody going postal. This is a planned event. This is somebody that has done their research and they know exactly what they're doing when they start the rampage. But we need to train our staff. Real quickly, lawsuits. There was a mass shooting in the McDonald's many years ago, and then we had Virginia Tech. A lot of case law established that a owner of a premises cannot be held responsible for a third party's action because those events were unforeseeable. Active shooters happen so frequent. Unfortunately, they happen so frequent in this country. And if we're training our employees, it's foreseeable. Okay. So we need to keep an eye on these case laws because soon, I believe, case laws will change and owners of properties will be held responsible for the actions of an active shooter because it is foreseeable. That was the key word when it was defended, that the premise owner cannot be held responsible. It was unforeseeable. Today, I think it's a foreseeable risk. So there's some statistics, not good. Every year, more and more active shooter events throughout our country. Unfortunately, probably by the time we go home and watch the 5 o'clock news, something happened in our country. So these are some horrific statistics. They're just continuing to increase. When you look at healthcare, we really don't have, knocking on wood here, not there was 3% of the shootings occurred in healthcare. One was really identified as an active shooter. What we see in healthcare is more of a determined shooter. Dr. Smith, you did not take care of my mother. You're going to pay for this. You, president of the hospital, your organization messed up and now I can't work, or you took my license away. I just had a recent threat where we took a license away. An organization took a license away from a 90-year-old individual that had a lot of experience with explosives in his prior life. and threatened to do some damage to this organization. And obviously, we had to take that threat incredibly serious because of his background. But um, we see more of a determined shooter where there's a target already in mind. When there, and we see that with murder suicides too. My wife is struggling. I don't want her to suffer anymore. I'm going to come in. I'm going to end her life. Then I'm going to end my own life. So that's typically what we see in healthcare. But these are the multiple approaches that are out there. So we have run, hide, fight from the Department of Homeland Security. There's ALICE. There's get out, call out, hide out, take out. These are all different programs. Um, the Department of Homeland Security is probably the most recognized, but it may not work for your organization. So if you don't have a training program that you're utilizing today, I would strongly suggest do your research, look at all these different things. Some of these programs will actually provide certification training for your staff who's going to provide active shooter training. And I always encourage that. If you have anybody providing either didactic or hands-on training, they need a certification. They need some type of backup. So if you don't have a current program that you're teaching, please do your research. These are some alternatives for you to investigate and choose the best approach for you. What is the easiest to deploy? What's the best to deploy? And then how you're going to train. I mean, online training is we probably all feel the same way. It's okay. It does serve a purpose, but it's not the greatest. We'd rather do live didactic training where you can get some good feedback and really answer some questions. And specific to active shooter, it's not only training, it's also muscle memory. And we'll talk about that as we transition into conducting exercises. But you have to choose your approach first. Then you have to train your staff. And every staff has a different role. So I went to an organization, everybody was getting the same training. And I said, that's great. But I think security's role is a little bit different. They need a little bit different training than everybody else. The voice operator who's getting the phone call to make the overhead announcement and call 911 needs some better and different training than everybody else is getting. The emergency management team needs different training. They need to know specifically what is their role. So you can't paint the whole employee population with one training. It's great for basic, but you really need to have very specific training based on the roles that individual is going to perform. God forbid the unthinkable happens and there is an active shooter. But these are the basic things: emergency codes, their escape routes. Really know those pre-incident indicators as well. When we talk about workplace violence, is there a change in somebody's behavior? Did somebody make a threat? All those different things need to be part of the training so we can reinforce to the staff the importance of reporting that information to their leaders so their leaders can do a risk assessment and then take the appropriate action to mitigate the risk. So in my organization, Virtual Health, we've been doing active shooter exercises since 2007. There are still many organizations today that don't do active shooter exercises because of fear of, causing undue stress. If you're not doing active shooter exercises and you have some reluctancy in your leadership to support them, again, please feel free to reach out to me. My contact information is on the presentation. So we do a very low stress active shooter exercise. This is the checklist. Every year we modify it because we learn from it. This actually walks our safety officers through what they do 2 weeks prior to the event. So we make every active shooter drill announced. We provide training a month before the exercise. So we want to set people up for success. We want to train them and then exercise the training. So it is stressful. When you hear attention please, this is an exercise, code active shooter, that still creates stress, and it's okay. We want to create some stress. We also want to make sure that our staff creates that muscle memory. So I've seen employees that had to go out in the hallway to take their key and put it in their door to lock it. Their hands were trembling so much they couldn't even get the key in the door just from hearing the overhead announcement. Muscle memory has to be created. We train our staff with the method that we choose, and then we exercise it. If you can't do a full-scale exercise, at least consider doing a tabletop exercise. A lot less stressful. You sit around a room, you give the staff a scenario and say, okay, what would you be doing now? Who would you be calling? What should they be doing? And you can really just talk about it, but really, you really need to exercise it. I think it's becoming the industry generally accepted practice is to conduct active shooter exercises. And feel free to steal this checklist. So a couple of quick takeaways. We all know what an active shooter is. Unfortunately, we all know that they occur all too often in this country. If you don't have a program currently in place in your organization, choose an approach, do your research, look at the one that is best for your organization, because every organization has a different culture and serves a different population too. So just, you choose the one that works for you. Train your staff, develop your policies, and then exercise your plan. Exercise your plan, exercise your employees, but always try to set them up for success. And then afterwards, we always do a hot wash. What went good? What didn't go so well? 99% of the time it's communication. I didn't hear the overhead announcement. I didn't hear the alert, whatever it may be. But we have to do these exercises. We have to evaluate them. We have to constantly improve with it's continuous improvement. So I know it's kind of fast paced, but I'm going to move on to mobile worker safety. So in research, in preparing for this presentation, I did some research, and I was kind of blown away. Today, 70.2% of the U.S. workforce is what is referred to as deskless. They don't have a desk to go to. And I was blown away. And then in 2030, it's going to be as high as 80 to 85%. I just found that fascinating, and I'm sure that COVID had a lot to do with that. And technology, the embracing of the technology allows us to be mobile, and we could be working from our cell phones, we could be working from our homes, we can work anywhere that we have a connection today. But mobile worker safety, specifically in healthcare, we have a lot of employees that never come into the facilities. They're working at home or they're working out in the community. So we have paramedics, we have home care staff, early intervention staff, we have behavioral health technicians that go into a patient's home. They may go to a homeless encampment to do vaccines, or they may go to a homeless encampment to provide behavioral health services. So we have a lot of employees that are out in the communities, and it's our responsibility, as mentioned earlier, to include them in our violence prevention program and make sure that we're giving them training and education and tools to keep themselves safe. So these are the statistics. I mean, it's just, to me, it's fascinating with how many employees are actually working, not within four walls of a facility or working on a desk, and that trend is just going to continue to increase. Even just home care. There was an article I found that said the home care industry is expected to double in the next 10 years because of how the aging population is. And the reality of it is, for those of us in healthcare, hospitals are going to be in the future. Hospitals are going to be reserved for the very, very, very sick. Everything else is going to be done outpatient. Hips, knees, transplants. It will eventually be done in the outpatient setting, and most healthcare services will be in our homes or through a device. So telemedicine or somebody coming to our house, because from living longer, we want a higher quality of life and we want to stay in our homes. So this industry, the home health industry, is just going to continue to boom. I mean, there are organizations today, I think this is really cool, that are discharging patients with a laptop, a wireless pulse ox, a wireless scale, and another device, which is slipping my mind, where they discharge the patient to get them out of the hospital because they can actually be cared for at home. And then remotely, in a navigation room, there's employees looking at computer monitors, which is looking at my heart rate, my blood pressure, and my pulse ox, and my weight. And if my heart rate is a little bit higher than it should be, they call me and say, "Mr. Sarnes, did you take your heart medication today?" Or, "Mr. Sarnes, we see your heart rate is really, really elevated. We're going to dispatch a paramedic to your location right now." So this industry is, to me, it's kind of untapped, and it's really where the future is going to lie when it comes to healthcare. The challenges are significant, right? We have staff working by themselves. We have staff that are working in incredibly high crime areas. And we know that there's safety in numbers. In someone's home, you don't have the ability to push a panic button and get security to respond. You have the ability to get other response, and we'll talk about that in a moment. But for those of us that have been in healthcare for so long, we're used to having a security force or people around us which can help us in a clinical or a security emergency. Out in the community, you don't have other staff to depend upon. So we have to make sure we're giving our staff training, education, and the tools to keep themselves safe. Workers are constantly on the move. So I could be at this address in 15 minutes, and a half hour later, I could be at a different address. So it's a challenge from a security perspective, and there's technologies and solutions out there that will help us keep our employees safe. Communication is always the number one issue, right? I say this all the time. It's the number one thing that breaks down in a relationship, and it's the first thing that fails in an emergency. But it's always the number one reason that employees don't feel job satisfaction. I don't know what's going on. Nobody's communicating to me. So communication is incredibly important. There are some great mobile solutions out there. And if you do have a mobile workforce, I would strongly encourage you to start looking at them. It's our responsibility to provide our staff with training and education so they realize the risk. What we do in Virtual, we've been doing this for decades, is we provide a crime map. We serve a very large footprint. And there's a crime map for each of the counties that we serve, which tells the staff green, good, lower than the national crime rate. Yellow, red, bad. Red is a high crime area. It doesn't mean we don't go into that area and provide services to the people that need our services. We don't eliminate any areas. But what that red tells our staff is in that area, you need to have a higher sense of awareness. In that area, you may consider, if possible, doing a daytime visit versus a nighttime visit. In that red area, you may consider, if the resources are provided by the organization, you may consider doing a 2-on-1 visit. So have two providers go out for the safety numbers. Or if the organization provides security escorts, call security escorts. If it's a police municipality that you have a great working relationship, in that red area, could I have the police officer at least aware, the police department at least aware that I'm in that area? So if I do call, that you know where I'm at, and you'll have a quicker response. Recently at an organization, which I haven't figured this out yet, and if you're any of you on the webinar that can help me, I appreciate it. I had a client ask for a map for police response time in a very rural area. And I said, that's fascinating. I never thought about that. I said, well, the average is normally 3 to 5 minutes nationally. And they're like, it's a half hour, 45 minutes here. Some areas are 5 minutes, some are 40 because it's that rural. So I thought that was a really interesting ask. But we need to provide training and education. We need to make, if they're in the community, teach them how to do windshield surveys, teach them about what is suspicious behavior, teach them situational awareness. All those different things is our responsibility to teach those that are working in the community. We have to provide it with communication. So everybody has a cell phone today. Most organizations provide their employees with a cell phone, but we need to make sure it's a working operational cell phone. If there are signal strength issues, we need to tell the employee where those areas are. But we need to make sure that we can communicate two ways, right? I can send a message to the employees out in the community that something is happening. They can send a message back to me that they need help or that they're okay. So the technology exists to have that two-way communication. Data on the fingertips. On my phone, I can tell you where the police activity is. I can tell you when the bridge is opening. I can tell you where there's high volume traffic. I can tell you all those things for an app I have on my phone 24 hours a day. It brings up the map of where I am located. It has me as a pin dropped, and it shows me everything in the community that I need to be aware of. It also tells me weather warnings. I can click on a little button. It says, yep, weather warning in this area, snowstorm, hurricane, tornado, whatever it may be. So that technology is very powerful in the hands of our employees that work out in the community. Staff accountability, God forbid something happens. How do we know our staff is safe? Something happens in a geographical area. Technology exists. We can draw through geofencing, draw a circle on a map and say, everybody inside that circle, this is the message I want you to get. And I want you to acknowledge that you're okay. So in Jersey many years ago, we had a train leak, polyvinyl, it was a chemical, I forgot what it was. And we had our home care staff, our paramedics, everybody was in that area. We were able to use the technology to push a message to them through geofencing. And it required them to acknowledge to us that they were okay, so we could do that staff accountability. So these tools are just phenomenal in the hands of our employees. Confirming that staff have arrived. There's technology that's at the fingertips, which allows staff to set virtual escorts It's going to take me 20 minutes to get there. I'm going to set my clock for 20 minutes. After 20 minutes, if I don't acknowledge that I'm there, it could send an alert to my supervisor. It could send an alert to security. It could send an alert to the local police dispatch and get me the help. Powerful stuff. SOS. It's almost like a panic button on your phone. Again, 24/7. I need help. I push a button that's on my phone that's open at all times, and I will have the help I need. It drops a pin at my location. As I start to move, it leaves breadcrumbs so that the first responders can find me. This technology is affordable. It's easily deployable, and it's so embraced by the staff once they see how it works. Once they embrace the fact that the employer is not tracking their location, because the only time that the GPS pin is dropped is when they push the emergency button. Your staff loves these things, and I've had a lot of success rolling these out in my organization. So it's great having this information or this equipment at their fingertips. Virtual escorts, that's kind of setting the clock for when I should arrive. Again, if I don't arrive, it can send out that alert. Check-in requirements, I think, is another really cool tool. We can force a requirement for an employee to say, yes, I'm here. I'm good. Thank you. Thanks for checking. And that data is tracked back by the employer to, again, ensure that the staff is safe. Really cool stuff. Um, from a mobile workforce, for those of you that have mobile workforces, the first thing I would suggest you do is sit down and talk to them. They'll tell you where the risks are. they'll tell you how they feel safe and how they may not feel so safe. I would start there and then start looking for the solutions with them as a partner moving forward. So what can we anticipate going forward in the future? If you would Google, the risk that are coming our way, this is it, emerging diseases. We went through H1N, we went through SARS, we went through MERS, we went through H1N1, we went through COVID, we had the Ebola scare, and for those of you that are I know you're watching this, but the CDC has identified Uganda as kind of the emerging hotspot again, and we need to be very prepared to receive Ebola patients. We need to ensure that our staff knows how to identify a patient, that they know who to inform, and then how to isolate that patient before they would package for transport. But these diseases morph every year. At our last board meeting, I said next year it's going to be H5N25. We don't know what it's going to be, but we can, based on our experience with COVID and the impact that had on staffing and supply chain and the economy and drug abuse and alcohol abuse and increase in mental illnesses. These are significant events we need to be prepared for. Extreme weather is something that is a constant threat. We see this every year with droughts and wildfires and hurricanes, and the world is changing. The world is getting warmer. And these events will, again, impact staffing. They will impact our organizations. They will impact our supply chain. They will impact our utilities. We need to make sure that we have very robust emergency operations plans to address these emerging threats. And cyber is everything, right? Unfortunately, there's been hospitals that have closed because they could not financially recover from a ransomware attack. So this is something that many of us may not be personally responsible for, but we really need to work with our IT partners to make sure that they have outstanding practices in place for preventing malware and viruses, and that they have a disaster recovery plan so that we could quickly recover and bounce back and get back to the operation of providing healthcare. If you have not ever practiced your disaster recovery or practiced having a ransomware attack or having an attack that comes in through a radiology piece of equipment or comes in through your presence sensors that are detecting somebody in a room so it can turn on and off the lights. These are all devices that have been attacked to get into networks. So doing an assessment, working with your IT folks, doing that assessment to make sure you have those plans in place, I think is paramount. And then exercising them, because if your IT team has never exercised it, you don't know how they're going to respond. So we as professionals in this field, we can certainly help by facilitating some of those discussions. So I know I talk pretty quick, tried to cover a lot of information in 45 minutes. At this point, Andrea, I'll turn it over to you and see if we have any questions from the audience.
Great. Thank you so much for the presentation. We will move on to the Q&A. There's still time to submit your questions using that Q&A tab at the left of your screen. We have a lot of great questions already, and we will try to get to as many as possible. For the first question, can you give examples of de-escalation training programs? We've been having trouble finding them that are geared toward healthcare.
Well, okay, yeah. So there are a lot of great ones that are geared towards healthcare. Certainly, I'm not promoting any of them, but I can tell you some of them. Um, Crisis Prevention Institute's nonviolent crisis intervention is really geared towards healthcare. MOAB is another one that a lot of organizations use, management of aggressive behavior training. Um, the majority of those that I presented on this slide really are targeted for healthcare. And really, again, those populations, there's some that are really geared towards more geriatric, some more for the pediatrics, more some for the DD populations that we serve. So I would really look at those as really a start. And again, please use me as a resource. Just if you have any questions, any concerns, just send me an email, call me. I put my cell phone on the last slide, so feel free to reach out to me.
All right, next question. Do you provide psychological support or peer support after your drills, and would this be something beneficial?
Great question. So I just came right to my memory. I actually got chills. I had an employee. I didn't know this. Again, going back since 2007, we've been doing active shooter exercises. I had an employee that called out every day that we did an exercise. I didn't know this for about 5 years. She had trauma in her life, and because it was an announced exercise, she took a paid day off. When she brought that to my attention, I actually included her in the planning and included her. I'm always the bad guy, so I had her walk with me, um, and that was still traumatic for her. So after that day, myself and our emergency management coordinator and our emergency management team got together and said, one aha moment. Didn't realize that this is that impactful. Um, we don't have a structured for it, so it's not something that's part of our debrief, like where we say, okay, the employee assistance program is going to be here at 2 o'clock, 15 minutes after the exercise. We don't do it that way, but we do ask all of our department leaders, and we have employee safety reps. So every department has a safety rep. That's kind of our eyes and ears out there. If they hear somebody that's struggling with it, we will reach out to them and offer them. If it's an employee assistance program, if it's peer-to-peer counseling, or if it's other behavioral health services that they may require. Because it's telling us when that comes to our attention, somebody needs help. Somebody needs help processing pain or an experience. And it's our duty as an employer to make sure that we're providing that support to them. So, although we don't have a structured program right after the debrief, we do provide services to those that we identify that are struggling and need some help. And just to
All
say this too,
right,
and I think
next
by
question.
announcing the exercises, we can avoid some of that stress as well.
All right, next question. What app are you using that gives you all the info on the location around you?
That's cool. We have Everbridge as our mass notification system, and we deployed about 3 years ago. We deployed the Safety Connect. So we deployed it for it took off like gangbusters. It was cool. We deployed it to our home care staff, which is over 400 employees, and then we then deployed it to our early intervention team, which provides services to kids from 0 to 3 years old, OTPT stuff. We then deployed it to our mobile market. So we operate a mobile farmers market, a mobile grocery store, a mobile pediatric van. So every one of our employees, which is probably 800 to 900 employees that are community based, every employee has the app on their phone. We provide the employee with the phone. The app is already on it. We are fully transparent. Within those groups, there are two unions. Um, and the union initially pushed back and said, "Oh, you're tracking us. You're tracking where our staff is," and we were able to demonstrate to them, we're not tracking. When we need to know where you're at, when you need help, you want us to know where you're at. So once we got the union on board, the staff really lined up for it. And it was funny because after the first appointment by home care, we wanted to do a 3 month kind of pause, evaluate, see where we're going. And unfortunately, we didn't have that chance. Um, and I should say, fortunately, others wanted it so quick. So we quickly deployed it to our early intervention program, and quickly deployed it to our mobile market. So the staff really love it. Even when we were doing the trial, it was all about creating confidence in the system. So I had every one of the alerts during the trial come to me. So I had to personally call people, and it was so it was 9 o'clock in the morning on a Saturday, at 3 o'clock in the afternoon on a Sunday, that people were testing the system to make sure it worked. And we created the confidence by getting them that call right back and say, I can see exactly where you're at. You're at the Dunkin' Donuts, aren't you? So it was cool.
All right, another question. Given the variety and severity of critical events, including workplace violence events, how do you think health systems are expanding the risk information they monitor?
So great. Technology is wonderful today. I mean, most of our organizations have somebody that's monitoring social media or monitoring publicly available information. If you don't have somebody that's tracking that information, certainly because you can identify threats through social media just by tracking the name of your organization. So looking at things like Instagram and Facebook and Twitter and other chat areas, and then really looking at that information that's publicly available through the news media. If you don't have somebody in your organization that's actively looking at it, there are certainly solutions out there. There are plenty of organizations that provide that service to you. So many organizations that have a large footprint, really, I strongly advocate for this. Okay, so if I'm a director of safety and I'm responsible for 3 states, I'm going to live in one of them. Okay, the news media that I watch is from my state and from that region. I have no idea what's going on in the 2 other states because I'm not seeing it on the news. I'm not reading it in the newspaper. So if I have responsibility for a large geographical area, I want somebody pushing that information to me. Tell me what the threats are, so I'm aware from a weather perspective, from a violence perspective, so that I could then prepare my staff accordingly. I can come up with mitigation strategies. So again, if you don't have somebody that's looking at that internally, there are a lot of great solutions on the market today.
All right, another question. How are emergency departments ensuring the safety of the patients during an active shooter?
So this is always a tough question to ask, or a tough question to answer. So we train our staff to run, hide, or fight. If they run and they ask others to run with them, and they don't run with them, we don't want them to go back and get them. We train our staff, if you are in a patient's room when the unthinkable happens, um, we want you to stay in the room, right? So if you know where danger is, run from danger. If you don't know where it is, barricade yourself in the room. And then closing the door and barricading that door is protecting the patient in the room as well. There's no right, wrong answer. Staff is going to respond how they respond. A clinical person with a license will not lose their license for running away from an active shooter. It is not patient abandonment. Hard questions inside our ICUs and our pediatric ICUs and in our operating suites, because you have somebody's life in your hands at times. We still tell our employees, you have to maintain your safety. We can't take care of them after the event if you're not safe. It is a hard conversation to have because it's counterintuitive that against everything that we came into this profession for, taking care of people, and now I'm protecting myself and maybe not protecting the person that I'm charged to protect. So there's no right answer. Teach your staff to take care of themselves is how we do it here. Certainly, if there's opportunities for our colleagues to protect others, like patients and visitors, we should teach that as well. Think about this: the main lobby and the receptionist is working there. I mean, we pre-identified where we can house everybody that's sitting in the waiting area, and that's for a weather emergency as well. If there's a tornado warning, we need to get them out of the main lobby into the corridor, into a secure place. So we have that responsibility, but you're always going to have folks that are going to question how you answer that question, unfortunately, because it goes against their moral instinct.
All right, another question. Are there any suggested examples or templates to assist with the workplace analysis?
There are a lot of tools out there that are available on the line online. I think the OSHA tool is probably the best. 1148, I want to say it is. Um, and it's a pretty comprehensive checklist. Realizing that there's, if you look at it, it's cool. It's a good tool. Um, but I think once you look at it, you're going to realize there are some opportunities to enhance it. Um, that's probably the most recognizable tool out there today because it does really look at the totality of the healthcare environment. That's a good one. The American Society for Healthcare Risk Management has a good tool. Um, those are the two that I, full transparency, created my own tool using the best of all of those that are available, and then inserting some of my experience over 34 years, and that's how we create our assessment. And then the other big thing that a lot of folks don't include in their assessment, the environment's easy. It really is. You look at access, you look at surveillance, you look at lighting. It's the staff interviews that people don't really take time to do. So if you're doing that assessment, take time, sit down at the nurses station, talk to the nurses, see how they feel. Because security and safety is not something that is necessarily tangible, it's a feel. If you're not including workplace violence prevention questions in your culture of safety or your staff engagement or staff satisfaction surveys, great opportunity to get a baseline as to where your employees are coming from. Every couple of years here in Virtual, we do a security opinion survey. We ask our employees, and so we're 15,000 employees. We'll get about 35 to 4,000 responses, which is a pretty good return rate. And we ask them a couple questions. Have you used security in the last 12 months? Yes or no? If yes, were you timely, professional, courteous, and knowledgeable? Most important questions are, what are your suggestions for improvement? What what areas of the facility do you not feel safe? We get some powerful information there. 20 years ago, I had this aha moment. I had no idea we had a medical records employee working the 11 to 7 shift in literally what was a basement. It was actually a sub basement. So there was a cellar and then there was a basement. We had no idea that she was working there. No idea. She had no phone. She had no panic button. She had nothing. And we got that information from the survey from her directly. So I think there's a lot of value in asking those questions.
All right, well, that was our final question for today. We had a lot of great questions and couldn't get to them all, but we will try our best to get back to everyone who submitted personally after the webinar. Thank you for attending this Fierce Healthcare webinar and for submitting so many great questions. I'd like to thank our speaker for participating and Everbridge for presenting today's webinar. Thank you for joining, and we look forward to seeing you at future events.